Good afternoon, everyone. Thank you for joining the Bundle Payments, the Path Forward webinar. My name is Amol Navathe. I'm the director of the Parity Center here at the University of Pennsylvania, a physician and a health economist, and have had the great pleasure of spending a good portion of my professional career studying bundle payments, hospital payment models, specialty payment models, and the like. So over the next 90 minutes or so, you will hear what we think is an exciting program covering the current evidence and best practices around bundle payments and the policy path forward, including presentations by key thought leaders, policymakers, providers, and then subsequent to that, a moderated panel discussion that I'll have the pleasure of moderating. So if we take a step back and think about why are we doing this today, I would say that episode-based payment models, or bundle payments, as we're going to call them today, are at an important inflection point. So for those of us who may be less familiar with bundle payments, let me just take one step back and say, what are bundle payments? So bundle payments are essentially a way for purchasing services, healthcare services, in a bundled fashion, hence the name bundled, or in an episode fashion, hence the name episode-based payments, that are clinically meaningful. The canonical example of this has been hip and knee replacement surgery, oftentimes referred to as lower extremity joint replacement surgery, where if grandma or grandpa needs a new hip or a new knee, we would typically pay in fee-for-service with this in a very piecemeal fashion. So the anesthesiologist who provides the anesthesia for the surgery, the surgeon, the hospital facility, maybe even the skilled nursing facility afterwards, any post-discharge visits, all of those would get paid separately in a piecemeal fashion. The idea of a bundled payment is to take all of those payments together and bundle them into what we call the target price. And that lets hospitals and physicians know exactly what our expectations are. We actually set that, so CMS or a payer would actually set that as the target price against which, if the net payments overall, the gross payments, as we aggregate all the payments together, exceed that target price, then the provider actually would end up paying back a sort of like a penalty. And if they beat that, they would actually get to share in the savings, in fact, a large portion of the savings that accrue subsequent to that. That is the concept of a bundle payment. It is set relative to quality metrics as well, and that's the paradigm of this value-based payment model, which is why bundle payments are a core strategy amongst CMS's different value-based payment models. The other thing I'll highlight is that the bundle payments are not a new concept. So the first model actually dates back to the 1990s, I believe, focusing primarily on bundling together the physician and hospital services for inpatient cardiac surgery. Subsequent to that, there was a model called the Acute Care Episodes Program. And then in the Post-Affordable Care Act era, we saw multiple different programs that we're going to talk about today because they form a lot of the core evidence base. As I mentioned, bundle payments are a key part of the overall payer value-based strategy toolkit, alongside advanced primary care models, population health models, as well as other specialty type models that may cross over between the population type and the episode type, namely in the kidney care space. In general, it seems like while with any payment mechanism that's new, there's been some fits and starts, but there's clear evidence where bundle payments have worked. There's other places where more work needs to be done, and we're going to highlight some of those in today's webinar. One other point I'll quickly highlight, and then we'll get started, is why specifically do this webinar now? Well, as many of you may have seen, CMS, the Centers for Medicare and Medicaid Innovation, Medicaid Services, and its Innovation Center, the CMS Innovation Center, recently announced the proposal for a new mandatory bundle payment model called TEAM, Transforming Episode Accountability Model, it's a mouthful, that would start at the beginning of 2026. This follows when CJR, the Comprehensive Care for Joint Replacement, and the BPCI Advanced for Bundle Payments for Care Improvement Advanced models would finish at the end of 2025. And this is part of a broader strategy that CMS has to get its beneficiaries aligned with some value-based payment model by 2030. That's every single Medicare beneficiary. So today we're going to hear about an overview of CMS's plans for the future, some key summary and synthesis of the evidence, and then reflections from our experts on some of the key policy areas. And with that foundation set, let me just go over a couple of housekeeping points, and then we'll go to our opening remarks. So our webinar is being recorded today. During the webinar, all audience members will be in listen-only mode. That being said, please feel free to submit questions throughout today's questions. We will collate them and try to include them into our audience Q&A portion. If we can't, unfortunately, get to every question, we will certainly keep those as part of future events, as well as FAQs and other resources that we build. Finally, we'll also be sharing a survey after today's webinar. Please take a few minutes to let us know how we did and how we can improve in the future. I will quickly introduce our panelists today. So first, our opening remarks will come from Sarah Fogler, who's the director of the Patient Care Models Group at the Centers for Medicare and Medicaid Innovation. In this role, she leads the design and implementation of physician and hospital-based alternative payment models. This includes a long list of models, so I won't list all of them, but for today, we'll highlight a few that we're really going to touch upon. So I already mentioned the BPCI Advanced model, the CJR model, and the newly proposed TEAM model. So those are the key ones that I'm going to highlight today that sit in the portfolio of work that Sarah leads. She has a long history of public service across various leadership positions at CMS, including past work on the Medicare Shared Savings Program. After her, we'll hear from Josh Liao. Dr. Liao is an internal medicine physician, tenured professor of medicine, and Walter Family Distinguished Chair in Internal Medicine at the University of Texas Southwestern Medical Center. Dr. Liao founded and led a nationally recognized policy evaluation unit that became the formal evaluation partner for the Washington Healthcare Authority, the largest purchaser of healthcare services in the state. And that was when he was on the faculty at the University of Washington. He is a member of PTAC, the Physician Technical Advisory Committee, which makes recommendations on payment models. And I'm delighted to share that he's also one of the newest members of MedPAC, the Medicare Payment Advisory Commission. After Josh, we'll hear from John Birkmeyer. Dr. Birkmeyer is president at Sound Physicians, an inpatient medical group with practices in over 400 hospitals nationwide. Since 2015, Sound has been among the largest participants in Medicare's bundle payments programs, including BPCI Advanced, initiating over 300,000 episodes. Before joining Sound, he was executive vice president of integrated delivery systems and chief academic officer at Dartmouth Health, and he enjoyed a long, distinguished academic career. He is credited with really propelling the field of health services research, specifically in surgical disciplines. Next, we'll have Davir Kaviyokoglu. Davir is a PhD economist focusing on impact evaluations of healthcare payment and delivery system reforms. After working in the private sector for a number of years, directing evaluations for CMS and other agencies, he's been at the CMS Innovation Center since 2014. He led the federal evaluations of bundle payments for care improvements, so BPCI as well, and is leading BPCI Advanced. Last but not least, we have Prakash Jayakumar, who I will reference as PJ. PJ is an orthopedic surgeon. He's an assistant professor of surgeon and perioperative care and director of value-based healthcare and outcome measurement innovation at the University of Texas at Austin Dell Medical School. Dr. Jayakumar has dedicated his career to the value-based transformation of health systems and specifically leading change through health systems research, digital health innovations, and healthcare policy and practice transformation. He received his medical degree from King's College London, his PhD from Balliol College, Oxford University, and Masters in Healthcare and Design from the Royal College of Art and Imperial College London. He came to the United States on a Harkness Fellowship from the Commonwealth Fund, and we've been very lucky to keep him in the US since then. So without further ado, let's hear opening remarks by Dr. Sarah Fogler. Sarah, I'll turn it over to you.
Great. Thank you so much, Amal. Thanks for the invitation. I'm really excited to be with this group today to share a little bit more on the thinking behind where we've been and where we're headed. And I'd like to start here, just picking up where Amal left off on his summary of the CMS Innovation Center's commitment and revisioning, if you will. So in the fall of 2021, we released a white paper on our renewed vision to build a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And with that strategic refresh, is what we call it in short, we anchored ourselves in 5 strategic objectives that would guide the implementation of the center's portfolio moving forward. Those 5 strategic objectives are driving accountable care, advancing health equity, supporting innovation, addressing affordability, and partnering to achieve system transformation. And as Amal mentioned, we set ourselves a bold goal of having 100% of Medicare beneficiaries and the vast majority of Medicaid beneficiaries in an accountable care relationship with a clinician who's responsible for their total cost of care by 2030. In 2022, we published kind of like a sub-strategic piece that focused on our interest in specialty care. And there were 2 particular metrics that we plan to assess our success on as we implement these strategic objectives. The first is improving specialist engagement in value-based care. And the second is supporting better integration of specialty care with primary care. Delivering, and these are built on the foundation that we believe that delivering person-centered care strategies requires addressing the full range of patients' needs, from primary and preventative care services to managing chronic conditions longitudinally, as well as the episodic care needs that can pop up and require specialty or specialized services, of course. And not to mention specialty care plays such a large role in overall spending. It's also an opportunity for us to try and move the needle on impacting healthcare spending overall. In terms of the specialty care strategy elements, each of the 4 elements we designed under the specialty care strategy support the center's larger accountable care goals. So building on our tests of acute inpatient and hospital outpatient department episode models, like Amal mentioned before with both the CJR model and the BPCIA model, and several of our condition-based models, we have work in the oncology space, in the kidney space. We have a new model launching in the dementia care space. The Innovation Center developed this comprehensive specialty care strategy that will support patients across the patient continuum of care. So the idea here is that we had done a lot of work in the acute episode management space and some condition-based work, but we had done less to move upstream to promote better integration among primary and specialty care providers. Our specialty strategy specifically has 4 components. And again, I can drop these links to our publications in the chat, or we can circulate them after the webinar today. But the specialty strategy has 4 elements. The first is around enhancing specialty care performance and data transparency. So improving specialist data to provide insight into who are the most likely to provide high quality, lower cost care to help clinicians make informed referral decisions. Strengthening efficiency and value of those referrals, which will help lay the foundation for more integrated care. And we have a whole host of new work that kicked off actually in January of this year to release shadow bundles data, which is really just code for the Medicare claims data for the items and services that we bundle into our episodes to total cost of care entities or organizations working to manage total cost of care on behalf of a population of beneficiaries. And the idea just generally with element 1 of the specialty strategy is that arming people with more data and information helps make better decisions. It helps people engage in partnership negotiations, and generally, ultimately will deliver better patient care, more timely, accessible equitable patient care. Before I turn to the second element of our specialty strategy and spend some time there, because that's where our bundle payment work sits, we have a polling question that we wanted to launch. So I will turn it to the team to launch that polling question. And this polling question is really just to get a better sense of how familiar folks are with the success of the episode-based payment model portfolio we've had in existence here at the Innovation Center. Okay, and here are the results, and it looks like success. 71% of the folks answered correctly. So it looks like we have a quite sophisticated audience here listening to the webinar today. So thanks for your participation. And now let me turn to kind of the further description of the 3 remaining elements of the specialty strategy. So the second element really focuses on maintaining our momentum in our episode-based payment work and also our condition-based models. It's been definitely challenging for us. I mean, the Innovation Center is charged with testing models that can eventually scale into permanent programming in Medicare and Medicaid. And so there's a lot, as I like Amal's phrasing, fits and starts. And I think that's because we're trying to figure out the right recipe. And so it has, definitely been challenging to strike the right balance across predictability and accuracy in our pricing methodologies. But despite that, our bundled payment portfolio has consistently generated gross savings to Medicare. So we continue to believe it's important to continue kind of chipping away at the right design here to ensure that bundled payments have a place in permanent programming moving forward. We also know that model participants in past CJR and BPCIA models have told us that they want to maintain momentum in value-based care. And so obviously we want to continue with the investments our partners have made in care redesign, and we're continuing our focus on episode-based payment models. We're going to dig into this more today, and I'm going to talk specifically about the new team model that Amal mentioned, and that is the next iteration of our episode-based payment model work. So we'll come back to that momentarily. The third element of our strategy is really on incentivizing primary care physicians and specialists to communicate and coordinate better on behalf of their shared patients. And again, this is in the spirit of moving upstream of the past work that we've done that's primarily focused on acute hospitalizations and post-acute care. So we have a new model that's actually launching July 1st. It is a primary care model called the Making Care Primary model, but it has a number of explicit specialty integration strategies that we've introduced. Promotion of e-consults, some funding for e-consult platforms, new codes for specialists to build to engage in this shared patient management of chronic conditions. So there's some interesting strategies that we'll be testing in that new primary care model to try and pull specialists into these value-based care arrangements. The second component of this element 3 of the specialty strategy, we're still in the throes of designing right now, and we're going to ask some questions in this year's PFS that you can see by virtue of a request for information around some other ideas that would complement our primary care portfolio, but apply more specifically to our specialty care practices. So more to come on that one, but we're thinking about some condition-based opportunities for specialty practices to, again, help us move the needle on value-based care and figure out some new strategies for payment. The fourth and final element of the specialty strategy is around creating financial incentives for specialists to affiliate with ACOs and again, move into value-based care arrangements. We're considering a few different levers here, including a targeted set of ACO financial incentives to better manage specialty care. We recognize that ownership structure of the ACO really matters in terms of where they tend to focus investment to reform care delivery and increase return on investment. So this work, compared to the other elements of our specialty strategy, is a little farther out, but I'm happy to report we've had a lot of deliverables actually already come out on elements 1, 2, and 3 of the specialty strategy. Movement on 4 will be reported out likely next year. And we do have a health affairs blog that summarizes all of this more in depth, and I'm happy to, again, circulate that link. So next, we're going to turn to team and dive a little bit deeper on this new alternative payment model that we've been conceptualizing in direct support of element 2 of our specialty care strategy. Before I move into that, though, we have one more polling question for you. So I'm going to turn it over to the team to launch that one as well. Okay, well, so let's talk about this one, because we actually have been able to demonstrate Medicare savings. So we'll spend some time on this. Surgical episodes have definitely consistently resulted in gross savings, I think. And there's some more detail on here, but some of the savings opportunity that we've been able to establish in our episode-based payment models in the back, there's a difference between gross and net savings. Gross savings are what we're able to achieve at kind of the highest level before we are paying out shared savings to our model participant partners. So we've consistently been able to demonstrate gross Medicare savings. Where we have had some trouble is crossing the threshold on net savings. And that's just been a function of policy decisions that have been made. COVID certainly introduced some flexibilities. So there's been some policy changes along the way that have caused the performance of the episode-based payment models to move in a net negative for the program. But as Amal mentioned at the top, there's still a lot of promise given the gross Medicare savings opportunity and also our ability through these models to maintain or improve quality. So I know the panel is going to spend more time on that one, but let's now move into TEAM so I can dive deep on some of the key features that you have probably seen, or if not, you will see as you peruse this year's IPPS rule. I will say that the comment period is still open. It closes in 6 days, I think June 10th. So definitely looking for all the feedback you are willing to give us on the design proposals and areas that we're seeking comment. At a very high level, if finalized, the TEAM model would be an episode-based payment design that builds upon the lessons learned from previous CMS Innovation Center models, such as, again, CJR and BPCIA. The proposed design of TEAM was also informed by public comment received during a request for information that we released in the summer of 2023. Again, at a very high level, TEAM would mandatorily test whether hospital financial accountability for only 5 surgical procedures will reduce Medicare spending while preserving or enhancing the quality of care for Medicare beneficiaries. And again, for those of you that are not familiar with the statutory nature of the CMS Innovation Center, those are the 2 primary features that we kind of have to cross the threshold on to be able to move tested models into expanded form. As proposed, TEAM would be a 5-year mandatory model test for hospitals located within select geographic areas. It would not be a national model if finalized, and it would begin on January 1st, 2026 and end December 31st, 2030. If ultimately deemed successful in achieving improved beneficiary cost and quality outcomes, the model would inform permanent changes to Medicare service delivery and payment policy. I wanted to unpack some of what I'm sure is on the mind of reviewers of the proposal right now, those areas that maybe are most interesting as you're finding your review cycle ensue. So the first is the mandatory design of the model. Mandatory models we've found in the last decade or more that we've been testing models can improve the generalizability of model findings by overcoming inherent voluntary model challenges like selection bias and participant attrition. They can also capture a wider variety of providers from across the country, including many of those who have not participated in value-based models before when we've only had voluntary options available. Definitely acknowledge that some hospitals may be unhappy if selected to mandatorily participate in the model. However, as I previously mentioned, we've had qualitative interviews with past model participants who have invested a lot of money in the infrastructure and the processes necessary to make these episode-based payment models successful. So there is an interest in the Innovation Center continuing to do work in this space. We also recognize that transitioning away from fee-for-service to a value-based care paradigm can be challenging for hospitals that have not previously participated in an episode-based payment model. Reasons like these are why we have proposed a 1-year glide path to ease into the financial risk on those 5 surgical procedures. There's about 18 months between the proposals before the model launch date that we hope would offer sufficient time to prepare. I also wanted to tackle the proposed episodes and the 30-day episode length, the proposals around those. The RFI feedback that we got in 2023 helped inform this, but we worked to select episodes with sufficient volume that are clinically similar, have well-defined beginning and ends, and have demonstrated success in reducing episode payments and achieving net Medicare savings. Team would only test, again, 5 episodes among traditional Medicare fee-for-service bennies. The clinical episodes would be lower extremity joint replacement, which we have a long history in testing, surgical hip femur fracture treatment, spinal fusion, coronary artery bypass graft, and major bowel procedure. While the episodes that we're proposing for inclusion in Team are surgical, we're exploring additional episode categories, exploring adding additional episode categories into Team in the future, and we're seeking comment on additional episodes that we should consider. Any additional episodes that we would add would need to be through notice and comment rulemaking. In terms of the length of the episode, previous episode models, as many of you I'm certain know on this call, were a 90-day episode length or duration following initial hospitalization or outpatient procedure. The proposed episode duration for the 5 surgical episodes in Team are currently proposed at 30 days following initial hospitalization or outpatient procedure. This is thought that it will help us sustain the spending reductions achieved by previous CMS Innovation Center episode-based payment models and mitigate some potential unnecessary overlap with other models. As part of Team, the participating hospital would manage the patient during the episode and would be required to refer the patient to primary care services to support continuity of care. And I think what you can hear implicitly through that description is there's this interest of, again, in cases where patients aren't connected to primary care, connecting them to primary care, again, in the spirit of driving our accountable care goal. Let's tackle why hospitals are proposed as the mandatory model participant, not physician group practices. I'm sure the panel will discuss this later as well. Hospitals generally care for a high volume of Medicare patients and have the resources to assume financial accountability for episodes. Physician group practices, in our experience, are generally smaller entities and may not have the necessary resources or infrastructure to accept the level of financial risk required in Team. Physician group practices interested in Team may engage in financial arrangements with Team. You'll see some proposals around that as well in the NPRM. And it's thought that the model is designed, again, to complement the longitudinal care management policies and goals of accountable care organizations. While we did not propose to include PGPs as Team participants individually, we are seeking comment on this approach in the proposed rule. So I just wanted to conclude by saying there's an opportunity. This is a proposed rule. There's an opportunity to offer all sorts of comment on all the proposals, all of the areas for seeking comment. We're really interested in your thoughts on participant type and design, the clinical episode methodology, quality measurement, health equity, our pricing and payment approaches, integration with ACOs, and also there's some interesting new features to support the climate change priorities of the administration around voluntary reporting to support decarbonization, which isn't exactly relevant to, I know, what we're talking about today, but did want to put a plug in, would welcome all thoughts on that as well. So thank you so much for the time. It was a whirlwind, I'm sure, but it's a sophisticated audience. So hope that was helpful, and I will turn it back to Amal to take us to the next phase.
Great. Thank you so much, Sarah. Really appreciate it. So as you all can see, very active policy area right now, a lot of stuff in flight. Sarah did a very nice job, I think, highlighting key dimensions of the new model, as well as highlighting key areas where there's still some requests for information and active stuff there. So with that kind of setting the stage for us, so Josh Liao's come on camera. Josh will kick us off with the panelist presentations. These will be 4 shorter presentations from each of them, and we'll move into the moderated panel after that. So Josh, turning it over to you.
Fantastic. Thanks, Amal. And I'm really excited to participate in this panel and have hopefully a really active and thoughtful Q&A session with other panelists and attendees today. So while we spent the last number of minutes talking about the most recent models, what I'm going to spend the next few minutes talking about is really kind of taking a very quick review of prior models and what we found from them, and trying to kind of roll up some insights as I see them about, where are the areas in which bundle payments have been successful, where are some gaps in the knowledge, et cetera. And so what you see here in the table on the screen is really just a kind of brief summary at a very high level of 30,000 feet, so to speak, of some of the evidence related to large CMS bundle payment models over time. So I'll work through this just kind of quickly, column to column. If you look at the left, you'll see that I've lined up programs dating back to ACE, or the Acute Care Episode Program, which ran between 2009 and 2012, followed by BPCI, the Bundle Payments for Care Improvement Program, which ran 2013 to 18, followed by now two large and active programs, CJR, reflecting the Comprehensive Care for Joint Replacement program, which started in 2016 and will run through 2024, and BPCI Advanced, which began in 2018 at the conclusion of BPCI, and is planned to run through the end of calendar year 2024 as well. And the idea here, if we work through the columns, is that with the exception of the ACE program, which was kind of the smallest program that looked at bundling acute hospitalization, but no post-acute care, you'll see that there's one big overall down arrow in terms of spending for the rest of the programs. And that's meant to reflect that while the magnitudes may differ 1 versus 2 versus 3 or 4%, that the totality of the evidence suggests that participation in these bundle payments, be it from hospitals or physician groups, has been associated with differentially lower spending, aka episode-based savings in these models through the participants. Similarly, for utilization, you can see a down arrow related to post-acute care. That's what PAC stands for there. And that just echoes what you heard from Sarah earlier in the poll question about where the major benefit has been. And again, there's lots of nuance if you look at individual studies. For instance, a study in the Journal of the American Medical Association in 2016, looking at surgical episodes in BPCI, showed a reduction in post-acute care in any use of skilled nursing, inpatient rehab, or long-term care facilities. Contrast that with a paper published in 2020 in the British Medical Journal, looking at reductions in the days that patients spent in skilled nursing facilities as a driver of decreased utilization, and so on and so forth. So there is nuance in the types of changes, but overall reductions in post-acute care utilization, I think, is the theme. And then third, quality. What you see there is kind of what, meant to denote stable quality, that in the episode savings or decreases in utilization did not come at the expense of at least observable claims-based or patient-reported outcome measures there of quality. Now, admittedly, there are variations. If you look at each episode versus the program, there are nuances. There are a few things. For example, a more recent study of the BPCI Advanced program showed some differentially greater increases in healthy days at home under the program, but overall, the macro picture is kind of stable quality. What you see in that last column is just really for those of you who are kind of following this a little bit more, interested in, well, what about some of the things that I just heard about, physician group versus hospital? What about the interaction with other payment models, such as accountable care organizations or ACOs? What happens when hospitals or physician groups co-participate in more than one model, if that's possible? What happens when the care of these models overlap in the same patient? A patient is enrolled or attributed under different models. Are there spillovers, and what are the equity implications here? The high level takeaway is yes, there have been papers and evidence looking at all these issues, and I think they're very important and to talk about. Time compels me to kind of keep moving here, but if any of those things are interesting to you, would be happy to talk about those during the Q&A. And so if you drive down to kind of the lower half of the slide, that first box under the bright blue, really, that's, I think, the banner for me as I study the literature and think about the evidence for bundle payments at a high level, that they have generated episode savings via lower post-acute care use and spending without compromising quality overall. Now, of course, some of that nuance matters a great deal. The types of participants, physician groups versus hospitals, the co-participation or overlap, as I alluded to, with other payment models. The question of if a program is in a certain population, for example, Medicare fee-for-service, do we see quote-unquote spillovers? Do we see physician groups and hospitals changing behavior in such a way that affect the care of commercially insured or non-Medicare fee-for-service patients? Some evidence suggests the answer is yes, and it's important to think about those as well. And of course, the health equity implications. You've heard a little bit about the geographies and the ways that hospitals or PCPs in prior models have been able to elect or maybe have been mandated into these programs. What does that mean for the geographic access that different patient populations have to bundle payment programs? What about the types of selection, so to speak, that happen at the patient level as well? What about disparities and changes in disparities in outcomes? These are all really relevant. And so I think as we go forward today, obviously, much of the driver is thinking about savings and savings to the payer that implements these programs. But I think these other insights, the overarching point and some of the nuance here, I think are really vital in thinking about assessing success in a multi-pronged way. So I'll end my comments there and maybe pass it to the next panelist, but look forward to the discussion in the Q&A.
Great. Thank you, Josh. John?
Well, Thank you and good afternoon, everybody. If I could get thank you. I really appreciate the nice introduction, Amol, and just by recollection, Sound Physicians is a large inpatient medical group with a particularly large footprint in hospital medicine, and was one of the earliest and the largest participants in the CMS bundled payment for care improvement initiative. We ultimately left the program in 2022 as a result of both COVID hangover effects and changing in the pricing mechanism behind the program. We've continued to be quite active in alternative payment models around the acute care episode, particularly post-acute ACO programs and risk-bearing partnerships with large primary care groups. And so a lot of my insights are driven across all of those programs. Amal asked me to comment more specifically on what we've learned about the differences or the incremental effects of bundle payment programs as managed by accountable physician groups relative to hospital participation. And a lot of my information is driven by Sound's own experience in knowing what works within our own practice across 200 or 300 hospitals, but we also have the opportunity to work side by side with the BPCI and BPCI-A programs where the hospital was initiating episodes in parallel with us, which was really informative with regards to what works and what doesn't work. So as you can see outlined on this slide, the first column of the slide really is a summary of the most important drivers of acute care episode spending. First, let's point out the obvious that 45 to 50% of total episode spending is non-actionable, i.e. the DRG payment for the hospital that initiates the anchor stay. But the other elements account for the large majority of the other half. Now, if you passed the quiz that was administered earlier in the session, you appreciate that post-acute care, and specifically the use of SNFs and IRFs and home health, is by far the largest and the most actionable, element of acute episode spending. Probably illustrated in why the program was so successful in surgical populations. In our experience, hospitals and really their case management effector arm is very effective and very quick at turning the switch on in how elective surgical populations manage post-acute care, particularly with regards to moving from inpatient to outpatient rehab after total joint arthroplasty. But also underlying why spending has been harder to move with acute medical care, the hospital-based approach really has limited levers for more bespoke clinical care. In our experience, having physicians that have personal ownership, engagement, and in many cases, financial incentives around managing medical illness significantly outperformed hospitals with regards to the rates at which patients were discharged to SNFs and inpatient rehab after surgery. Component number 2 of episode spending is readmissions, which is about 10% or less of total episode spending, depending on which population that that we are focusing on. In general, whether it's managed by hospitals or by aligned physician groups, readmissions in our experience is an important but very difficult lever to move, and one that in absolute terms, we in hospitals were least successful in reducing through participation with the bundle payment programs. Where we've been able to move it, it's only been with the implementation of targeted incremental programs for dealing with high-risk populations, particularly patients that are in SNFs that account for a quarter of all readmissions to the hospital. Component number 3 is specialist use, something that often flies under our radar because it only accounts for, depending on how you count it, 10 to 20% of total episode spending. But, as has been documented by, work by Lena Chen and others, it's like arguably among the most variable of all types of episode spending. And what happens in the hospital has downstream effects on the use of specialist use testing and procedures after discharge, to the extent that inpatient hospitalists really are the primary drivers there. We've had a ton of success in reducing this type of overuse, particularly with regards to the use of so-called courtesy consults, whereby patients see their endocrinologist or their cardiologist just because they happen to be in the hospital rather than anything that is specific to their acute illness. And then finally, end of life care. In the medical half of hospitalized populations, in our experience, somewhere between 20 and 25% of BPCIA patients died within the 90-day episode. Just reminding us that patients get hospitalized at the end of life, particularly if it's admission with congestive heart failure, COPD, and some of the other common inpatient diagnoses. In our experience, hospitals had very little success in being able to reduce excessive intensity of care for patients that were in that stages of life. But in our experience, physician-led advanced care planning were very effective in reducing rates of surgery at the end of life, use of ICUs at the end of life, and among patients in that risk stratum, it significantly reduced rates by which patients went to a nursing home after hospitalization rather than home. So let me leave it there, but happy to take any of your questions in the later sessions.
Great, thank you, John. Daver, if I can invite you to the stage here.
Hi, everyone. Can you guys see me? I'm not seeing myself. That's why I'm asking.
Okay, yes, we can see you and we can hear you. So I think
Okay, that's
go
great.
ahead with your few minutes here.
Yeah. And I wanted to thank Amal for this timely panel. Not because CMS is in the process of rulemaking regarding the next generation of bundle payment models, but we also happen to have released the latest evaluation report just last Wednesday. So today, I'm going to focus my remarks on what the new evidence is and try to highlight things that might be different than before. As other panelists mentioned, bundle payment models have been successful and have been pretty consistent in reducing gross payments, mainly through reducing post-acute care. But whether those reductions led to net savings for Medicare or not, that was the challenge that CMS faced. That was one of the major reasons BPCI Advanced went through a significant design change in 2021, which is model year 4. And today I'm going to talk about the evaluation results, evaluating that first year after the design changes. Maybe 2 design changes to highlight quickly is there is in 2021, starting from 2021, there is now a retrospective trend adjustment, given the pricing issues in the past. And the other big change was participants now had to come in for groups of clinical episodes rather than sort of picking individual clinical episodes. They had to come in for groups of clinical episodes. So with those changes, what we observed in 2021 was the model generated, I would say for the first time, net savings to Medicare. That was almost $500 million in 2021, offsetting all the losses in prior years. So that's a change. This is a change because of the pricing, but the underlying mechanism remained the same. The mechanism to lower payments were still decreasing discharges to institutional post-acute care facilities, as well as even if the patient gets discharged to these facilities, length of stay was shorter. So that's where most of the savings came from. But given that the model maybe was not as financially advantageous in terms of pricing, there was significant attrition from the model. About 37% of participants left the model. However, model's footprint in terms of number of episodes didn't change in 2021. Actually, it increased, and the reason was the remaining participants agreed voluntarily to take on more clinical episodes because of the participation rules. So there were less number of participants, but responsible for about double of what they used to be before 2021. One of the interesting things that we have started observing, and I wanted to highlight, was the ability, maybe somewhat unexpectedly, but when you think about it, it should be expected, of this model's ability to connect beneficiaries to value-based care. And the way to measure it was out of so every 3 beneficiaries that were in the model, only 1 of them were attributed to an ACO. So 2 out of 3 beneficiaries served by this model were not attributed to an ACO. And furthermore, the ones that were in the model but not attributed to an ACO tended to be more likely from disadvantaged populations, as well as tended to be more complex health-wise populations. So the model had a successful reach to these populations. And you can see the mechanism where these beneficiaries, especially for medical episodes, had to be hospitalized. And once they're at the hospital, automatically they're part of a bundle. So that sort of attribution rule is different from how ACOs have beneficiaries attributed. While these changes were happening, typically effects on quality of care in these bundled payment models have been roughly maintained, as Josh mentioned. But with the most recent evaluation report, there are some varied findings. For certain subgroups, there are some hints of effects going in both directions. Even though we do our best, the rigor behind these, for example, patient-reported surveys is not as best as it could be, given that we do not have a baseline data collection. So we can't necessarily causally interpret the results and say these are because of the model, but more likely than not, there are some things happening in both directions, which means we should keep a close eye in the next bundled payment model. And finally, the last bullet here, this model led to care transformation, not only for the beneficiaries or providers in coming in just for these DRGs, but there was at least qualitative evidence that participants utilized these new care redesigns for larger population beyond bennies that were in these episodes. And I'll just mention a few of the care transformation activities. One of them was we are now seeing also qualitative evidence exists, and we're going to look at this quantitatively, is that hospitals after discharge making an effort to connect beneficiaries to primary care, more so than how they used to be doing before. Participants changed the culture around discharge destinations. That's one of the other big changes. Use of data and analytics is another change. There are a number of changes that happen on the ground, and I'll be happy to answer any Q&As regarding any more details on any of these or other topics. Are you on mute, Amal?
Thank you. Thank you, Daver. So we'll move to our last presentation, certainly not least. PJ, if you can come on camera and present your slide, and then we'll move to the panel from there. Audience, go ahead and think about your questions, and you can start popping them in the Q&A as well.
Fantastic. Thanks, Amal. Really a pleasure to be with you all, and really enjoying the talk so far and looking forward to the panel discussion. So as I say, now for something slightly different, this is really an opportunity to just kind of walk or a whirlwind through patient-reported outcome measures as an opportunity for a tool or technology to drive success in bundle payment. And certainly based on our experience at Del Med, we've had a chance to successfully deliver and both evaluate procedural bundles and condition-based bundles across primarily musculoskeletal care and other service lines using PROMs. So PROMs, as a reminder, patient-reported outcome measurements, the subjective health status measures, all capturing data from the patient's perspective about their health without interference from anyone else. So it's really the best off-the-shelf metric that we would have in terms of driving the patient, reflecting the patient's voice and driving the use of data related to their perception of health into this kind of concept of value, and potentially as a numerator of the value equation, driving kind of value-based models and a value-based approach to care. Specifically, where PROMs, I would say, are today in relation to bundles, they've certainly shifted from the research to the clinical realm. There are a variety of different institutions using PROMs and capturing PROMs, and there's still lots of work to be done in the performance measurement level, and even kind of use on the front lines at the individual level. So we're really going through a bit of a major transition around the application of these tools on the front lines. And of course, the uptake has been driven by both carrots and sticks. I think there's various innovative kind of opportunities around reconciliation bonuses around PROMs, as well as mandates that have obviously come through with CMS and CMS's final rulings and mandates to drive uptake with mandatory PROMs capture. Notice I've used the word capture multiple times rather than collection, because I'm going to get to why we use capture and the application of PROMs in the building use cases is what this slide shows, rather than just collecting these numbers and not doing anything with it. So, it's a quick nod really to the backdrop here. There's an explosion of third parties and other vendors to drive utility and adoption of PROMs. But where do we need to go with PROMs tomorrow? And getting into this slide. As I said, it's a tool for driving team-based integrated care is what we've delivered in our experience, and hopefully the CMS team model. I think we win on the use of the word team in this webinar multiple times, but certainly, driving that approach to care, especially with considering specialty care, primary care, specialty care engagement, and that transition. And also secondarily, as Sarah nicely mentioned, the importance of having a comprehensive data and analytics backbone, of which PROMs will play an important role, especially with trying to bring transparency to decision support using this tool. So at the individual level, of course, if you just think about from the specialist realm, there's opportunities for clinical decision support and specialists using PROMs for both appropriate treatment selection. You look at a number and then decide whether or not to kind of go down a certain therapeutic route, but to also using PROMs as baseline assessments and then longitudinal monitoring. We talk about complications. Could this be an early warning system for triggering those? And so those are things to really inspire clinician uptake on the front lines, to say these are tools that can really affect change on the front lines. And then when you bring the patient in this lower left quadrant, from a patient engagement perspective, it's using PROMs for shared decision making. Our physical therapists use PROMs for goal setting, priority setting. Our surgeons use PROMs for deciding whether to kind of engage in surgical management, and potentially even discussion around prior authorizations exists there, and obviously tailoring treatment plans based on these tools. And then if you move to the right half of the slide, you're looking at PROMs. When you successfully capture PROMs, at an aggregate level, then there are certainly opportunities for care redesign, phenotyping, care delivery pathways, which is what we've done at Del Med, to look at more intelligent kind of data and outcomes from a grouping perspective of different populations that you're managing, and accounting for aspects of mental and social health, and making sure that we're delivering. This is a tool to deliver equity conscious care, right? And so that's the top right quadrant, and then the bottom right, of course, from the payment and policy perspective, once you've successfully captured all that, using this as a tool for performance evaluation and maybe even risk adjustment using PROMs combined with clinical factors, as well as an accrediting and benchmarking device. So it's a bit of a whirlwind through, all of the functions of PROMs. There's a lot there, but really, it's critical for considering this tool as an opportunity for team-based integrated care, and even the strategic direction that we're going forward in terms of thinking both about procedural bundles, but potentially condition-based bundles, specialty care bundles. And there's a myriad of challenges, but also opportunities that way. At the human level, there's a lot of culture change required around clinical decision support on the front lines. Technically, lots of providers, having to really think about PROMs with these mandates coming through, how we're going to integrate and implement these, and at a systems level, culture change needed around using these tools, on the clinical front lines. And in our experience, we've shown the benefit of these tools for showing value and improving outcomes at the condition level, as well as the procedural level. So look forward to questions and diving into that a little later.
Great, thanks PJ so much. So thank you to all four of our panelists for really fantastic presentations, and hopefully we've illustrated a little bit of the method to our madness and why we picked these four folks, because they have kind of complementary views on different aspects. John obviously very much brought the physician-led view around bundles. We just heard from PJ really thinking about the patient-reported outcomes, AI, phenotyping measurement, pathways, very, very much under the hood of how bundles are supposed to work. And then Daver and Josh both giving us kind of the CMS and the non-CMS academician peer review kind of 30,000-foot view on what's working, what's not working in BPCI Advanced, and Josh giving an even broader lens across multiple programs. So with that, let's start the Q&A portion. So if I can ask all the panelists to come back on video. To be honest, there's so much here. I could just ask you each questions for the rest of the 45 minutes or so, 30 minutes that we have. So I'm going to pick a couple of topics to spend a little bit more time on. Maybe we can go to a couple of panelists and have a bit of a discussion. So the first thing that strikes me is, there have been a wide variety of different participant types that have been included in bundle payment models that Medicare as well as other payers have led. So certainly, of course, hospitals have been the mainstay, started out that way. CJR has mandated hospitals in, but physician groups have been very, very important in their participation as well. We've also had a Model 3 under BPCI that was led by post-acute care providers, but of course, since then, we've kind of picked up more on hospitals and physicians. I will say we've noted in some of the work that we've done that in some episodes, for example, lower extremity joint replacement, hip and knee replacement, if you just counted the number of participants, there's actually more physician group participants than hospital participants. So as we think forward towards TEAM now, and I think Sarah did a very nice job of articulating some of the rationale of why mandatory and why hospital-based. I think obviously physicians play a really important role. John, you did a fantastic job outlining why they're very well positioned to do such important work. So I'm curious, John, for your thoughts now, given that TEAM is hospital-based, what are your suggestions? What is the way that TEAM can be effective in engaging physicians so we don't lose this really fundamentally important stakeholder in the care innovation process?
I really appreciate the setup, Amol. As various panels have alluded to in different contexts, I think there's a pretty clear line in the participants and in the levers that drive sort of elective surgical populations, and acute medical populations. And give or take, if you look at all of the participants, I think it's about 50-50 overall. Early participation by PGPs in the elective surgical population was mainly orthopedic groups, typically small regional orthopedic groups that recognized, to be blunt about it, a fairly easy win by, shifting their acute practices to like share in the savings associated with that practice. I think as the data, as we've observed and the data has supported, that's sort of largely a very quick, large one-time savings that is really hard to maintain, particularly if the pricing model has a ratchet that basically has you competing against yourself, like in where you ended up last year. But I think kind of the bigger challenge, so challenge one is if you define specialists as, elective surgical participants, is how do you keep them in the game, once you've like essentially gotten to the flat of that curve. I think the bigger challenge, both clinically and operationally, is with acute medical populations, and we use the term specialists, but hospitalists are really primary care physicians that work in the hospital, as you know, and they are, kind of the opportunity is a real ongoing, more challenging. But like, I think the thing that we, have struggled with is how to include them in a meaningful way relative to the other types of alternative models, particularly kind of the work that PCP groups are doing with ACOs and to avoid conflict and overlap, and B, to have the shared savings upside associated with like hospitalist PGPs meaningful enough to basically justify all of the uncompensated time that goes into the work. So much of it can't be delegated. It has to be done by a physician. Hospitalists already require huge subsidies from the hospitals just to cover their salaries. And, unless the model explicitly supports that time, kind of they're much better off just seeing more volume, or dealing with the types of performance measures that aren't value-based but really are just efficiency-based interests of the hospitals for whom they serve.
Great, thanks, John. So Josh, I want to get your thoughts on this too, particularly recommendations that you might have. But before we go to you, Daver, I'm hoping that you can just give us maybe a 30-second to 1 minute snippet of highlighting PGP versus hospital savings under BPCI Advanced from your contracted evaluation.
The findings have been really consistent over the years. Both provider types saved money on both medical and surgical episodes. There were some differences in terms of sizes of the estimates. For medical episode, it's been more or less comparable, really roughly comparable. The cost reduction generally under 3%. For surgical episodes, it ranged from 5% to 7 or 8%, and generally PGPs had a little bit larger decline. But there are challenges in defining what a PGP is. PGPs is very fluid, so we do our best to account for these. And so I would say the bottom line is they have comparable. They have both been successful in both episodes.
Great. Okay, so that in my mind, that kind of raises the stakes here, right? So physicians obviously have been effective, even when we look at the CMS contracted evaluations, where we're taking a pretty system, program-wide view. It's not just quote unquote positive deviant outlier groups like John's group that are knocking it out of the park. It's actually pretty systematic. So now, Josh, with that context in mind, and some of the key details that John had pointed out around operationally why physicians have an advantage in some sense on certain dimensions of practice innovation, what are you thinking? How do we do this right in teams so physicians don't get left out in the cold and patients then as a consequence suffer?
Yeah, it's a great point. And I would just underscore before I answer that kind of Daver's point that, in work that I and colleagues were able to do, published in JAMA Health Forum in 2022, we looked at this issue of PGPs and hospitals as well. And I think while we saw savings in both, I think a really important distinction is that the changes in patterns of care after hospital discharge were different across the two. So for instance, we saw differential changes in skilled nursing facility use for hospital participants, as opposed to more home health changes, differential among PGPs. And I think it just speaks to some of the underlying maybe infrastructure and kind of care change strategies that these different participant types can have. And obviously we need more research in those areas, but I think it's really relevant when we think about participant type. And so I think in that way, team is focused around hospitals, but I do think some of that evidence is very important to remember because as you mentioned, I think hospitals may be well positioned to do certain things, such as sharing high volume of patients with skilled nursing facilities, which may kind of potentially drive their ability to do that. Physician groups may actually engage with multiple hospitals and multiple SNFs in a way that drives what we're seeing in the data as well. So I think the overarching banner for me is that we need to find ways to engage PGPs in the models. And I think prior models like BPCI and BPCI Advanced suggest that we can do that. And so I'd love to see other models, or extensions of models do that in the future, team or otherwise.
That's great. Yeah, and I think one of the things that we've seen written about and we've written about also is maybe gain sharing. Are there ways to actually create some financial alignment between the hospitals and the physicians? So PJ, I'm curious to get your take on this. You've really been at the forefront of innovation of how to really get the best methods, the best technologies, the best reported measure, PROMs, really at the front line of care. So are these kind of gain sharing models, is that going to be enough of an incentive paradigm, you think, to get the hospital-based clinic, the physicians, the orthopedic surgeons, all the people that we need to be really engaged in this hard work? If I remember from my visit to your facility, a lot of the gains in managing populations and getting the right people, the right surgery is actually about psychosocial factors and depression management. I mean, this is not just about the surgical workflow. This is all about whole patient management. So can we activate them through a gain sharing paradigm? Is that going to work?
Yeah, I think it is, Amol. I mean, it's a great question, and I look at this and I go back to kind of Sarah's talk and really just in two axes of activity. One, the care transformation that's needed. And we've spent a lot of time trying to figure out what are the specific elements that we need to change from business as usual, right? And so our kind of approach has leaned into a comprehensive condition-focused management across the whole musculoskeletal specialty arena. And with that, I mean 80%, the 80%. We're not talking about the 20%, right? Just to qualify that, we're talking about the 80%, the osteoarthritis, the rotator cuff, the ACL injuries, the back pain, that kind of thing. And so we've really seen opportunities through work we've done, both in terms of using PROMs, but also the denominator of the value equation, looking at micro costings, total costs of care, pathway redesign, to then focus on where are the levers that we can pull. And quite simply, we've said, well, there's some real opportunities here in having a dyad approach to the specialty care. So we have an advanced practitioner who shares the load of the surgeon to see the patient. I mean, immediately you see a massive kind of cost saving opportunity there, because not everyone needs to see the surgeon, throughout the whole kind of technical, the episode. We've used, judicious use of physical therapy, very, incorporated telehealth for coordinated in-person and remote care, and also, really stressing the importance of reducing the utilization of low value interventions, which are rife in orthopedic practices, around advanced imaging for very straightforward things, injections of biologics and other things with scan evidence, compared to doing all of these other non-operative strategic approach. And then on the data side, I think PROMs have been a real driver for this idea of appropriate treatment selection. I think we use it for decision support across our team. I think it's really, really important because it's unlocking the utility of PROMs beyond just a measure that you collect and report your delta, but really using it as a decision support measurement. And so with all of that combined, those two tracks, the care transformation and the data to drive intelligent decision-making and coordination of care, I think, going back to your original question, I think there's lots to be, efficiency to be gained, and as well as gains to be shared if you get it right.
That's great. Okay, so thank you. So I wanted to pick up on one point. You made many, many good points, but there's one thing I want to elevate, which is, the patient-reported outcome measures could be a vehicle to actually incorporate some appropriateness, right? So, and appropriateness, just for everybody, just to make sure we're saying the same thing, appropriateness is basically referring to, should this patient really have gotten the surgery for this elective knee replacement? In particular, should they have gotten it now? Maybe they should have gotten it later instead, or something else like that, right? So that's kind of this concept of appropriateness that we're after, and that's really terrific. So, John, I want to ask you a question about that, because I think as I think about the policy reflections about bundles, one of the repeated things that we heard in 2012 onward was this concern that, man, you know what? We're just going to get a lot more episodes once we start bundles because surgeons are just going to do more procedures, right? And the evidence has repeatedly borne out. We did a study, Josh and I did a study many, many years ago. Mike Chernew and colleagues did another study. Karen Joint-Maddox and colleagues did another study. I think the CMS contractors have done studies as well that have not borne out this, volume creep or volume effect. That being said, that doesn't mean that appropriateness isn't a concern. So I'm curious, as somebody who leads a program that is of the scale that you have with the clinical acumen that you have, are bundles an appropriateness problem, or is this fairly settled? We shouldn't really worry too much about it.
I think that the answer is it depends. And, I think that for, acute medical illness, those patients, like by and large, don't get admitted electively. It's relatively non-discretionary. And, those patients just come in through the ED. So the potential for shenanigans around, gaming the total number of bundles is relatively low on that half of the ledger. But as you know, I grew up professionally with the Dartmouth Atlas of Healthcare, and kind of like Jack Wenberg would say, kind of what CMS should be focusing on is the volume and the number of procedures, not how can we shave off 3 or 5% of the total episode costs. And I think that's even more true, kind of once current payment models get more groups onto that flat of the curve. And I think that, while there is some creativity involved here, I think the best way to pull in real specialists that basically cross the continuum between ambulatory and inpatient care, let's think orthopedic surgeons or cardiac surgeons, would be basically gain sharing models where they're accountable within an ACO framework for total spend within, kind of that, within that particular specialty. So they're basically getting rewarded for their ability to manage total spend with cardiac specialty care, the number of procedures, as well as how efficiently they are performed.
Great. Okay. So super helpful. I think a couple of things to highlight there. So, and this is going to actually take us to an audience question, which I'm going to weave in here. So, or maybe even a couple of audience questions. So, you mentioned that there's what you're recommending is kind of a gain sharing model that has this interface between the ACO program and effectively episode management in some shape or form, whether it's a program or some other paradigm, as your group has done with ACOs. So, so I think that is interesting. One of the things that's a couple of features of Team, I think, that are important to highlight there. So Team actually allows for this kind of Benny to be in both models at the same time, and you can actually compute the bonuses for the ACO and the episode or the bundle payment hospital simultaneously. And so theoretically, there could be some double counting. There is some evidence, peer review evidence out there that the overlap actually generates some synergies. So this may not be a bad thing for CMS and may actually be a good thing for all the participants. So, so that's one thing. The other thing that CMS has done, and Joel James from the audience actually has this question about, there's a 30-day paradigm here. So the episode length is 30-day post-discharge. Conventionally, before this, we were talking 90-day post-discharge for CJR, for BPCI Advanced, and for the most selected model track in BPCI Model 2. So there's a lot of savings in that 30% for sure, although Joel says, we've done some work and we find there's a lot of savings after day 30. As I read through the Federal Register with a really big cup of coffee, I saw some rationale in there that one of the reasons is because they don't want to siphon savings away from the ACO. And so Aiden Crowley from the audience also has asked a question, and she directed this towards Josh. So maybe Josh, we'll start with you, which is, how big of a concern is this siphoning of savings / coordination piece? Is this 30 days a good place to start, or is it a magic bullet? Is there a lot of evidence around it? What is your sense, Josh, of how this really Herculean task the CMMI is up to is just trying to stitch together these models in a way that really makes sense? What's your sense of how we're doing on that? And is this kind of step one, we got to figure this out, or is this, we got the answer here, we're going to lead with that?
It's a great question. I appreciate it from the audience. And I think bottom line on top is I think it's something we got to figure out. I think it's a good start. And I think we need more experience and then more evaluation of it. Well, you alluded to this, but I think, there are, well, let's take a big step back. From my view, is overlap an issue? I think we've seen organizations describe the extent of it at a national level with some dated, what's now dated evidence. There is some sense that if you look at large bundle payment programs and large ACOs, such as the shared savings program, you're talking anywhere between 10 to 27% of overlap, depending on whether you think about it from the ACO perspective or bundle payments. Suffice to say, non-trivial. And then if you kind of think about, well, what does that mean when you think of overlap in a patient, even if, say, the bundle payment hospital or PGP is different than the ACO, or if you think about them as the same, meaning there's a hospital or a group that's in an ACO and also bundle payments. And so there are some nuances there, but as you alluded to, Amol, I think there are definitely dynamics there that really need to be thought of and managed, and both at the savings level, which is what the question is targeted at, but also the care delivery change level. And so historically, the way cost accounting has worked, the historical target price for bundle payments gets tied to the ACO. And if the bundle payment participant generates savings, it gets clawed back. And those are things that I think this approach you're describing helps begin to suss out, but we need more evidence there. And more to the point, what is happening to care delivery? In a prior role, I was fortunate to kind of work with an organization on our strategy around ACOs and bundle payments. And one of the takeaways is, do we implement more of a ACO type strategy, really focusing on building out primary care infrastructure, close follow-up, et cetera? Do we think about it more as a bundle payment strategy of addressing post-acute care? Now, those are not mutually exclusive, and yet you do see this differentiation. And it wasn't quite clear to us, the one or the other. And I think evidence there would be great. And finally, I'll say that the available evidence, though limited, suggests that actually there can be synergies, as you alluded to, but in the context of hospitals participating in bundle payments and ACOs, there can actually be some distortions as well, where you can see evidence of hospitals implementing perhaps more what I'm calling ACO-based strategies versus bundle payments. And sometimes it doesn't always come out to the benefit of patients. For instance, one analysis looked at unplanned readmissions and found that increased for hospitals that were in both. And happy to talk more about why, but I think we need to be careful and we need more evidence on this.
Great. Okay. So I see John's hand up. Before John, I come to you. I'm going to take a quick pit stop to our data guy, Daver. So Daver, if I can ask you, so Joel was estimating that they had 40% of 90-day episode spending occurring in days 31 to 90. So I want to quickly get your sense on, from your evaluations, is that ballpark what you're seeing, at least say in the team episodes? And then secondly, I wanted you to give us a yes or no, hopefully a yes, that the way I characterized the lack of volume expansion in bundles, is that consistent with what you all have found in your evaluations? So 2 quick questions to Daver.
Like on the 30 and 90-day episode, in BPCI Advanced, we did not analyze 30-day episodes. So what I may remember is from the past, like from BPCI, So my memory isn't that great. The number roughly sounds right, but I don't know. I should go back the publicly available BPCI report and see how it was there. So on the volume issue, yes, we have looked at volume once, I think for BPCI model 2, and we didn't see evidence that volume went up. We haven't done that for BPCI advanced yet. But we do analyze patient mix because they're interrelated. Like the volume may not go up, but if the patient mix goes down, that has implications. So we have a chapter on it in an appendix. People can sort of take a look how the patient mix might be changing. That's the only thing I can offer right now.
Okay, great. John, to you.
Just a quick follow-up on our own experience about the 30 versus 90-day thing. Over 7 years and 300,000 episodes. Overall, in acute medical populations, we reduce spend versus trend by about 0.8% to 1% per year. But when we looked at that more carefully, virtually 100% of that spending reduction was within the first 30 days, and we had negligible effect after that. So I think that in that sense, like, I think CMS is making the right decision in truncating it to 30 days and giving the last 60 days back to the PCPs and ACOs.
Great. Okay, thanks, John. So, all right, we are slowly coming upon time. I want to try to squeeze in, if we can, 2 quick topics. So one is outpatient bundles, and then the other is the MIPS AAPM issue and how it relates, the Advanced Alternative Payment Model bonus that people get for participation in MIPS and how that relates to specialists. So let's start with the MIPS one, because I think it's really pressing in some sense. I know there's some interest at on the Hill even about this. So the MIPS APM, just to recap for folks, in general, there's been a binary cutoff. If you have enough of your revenue coming through a value-based model, then you get this 5% bonus, and that's actually scheduled to go down over time, I believe. One of the things that has resulted in, that kind of a structure has resulted in, is if you're a primary care clinician in an ACO model, you're like almost definitely going to qualify. But if you're a specialist or a hospitalist, as John was highlighting, in a bundle payment model, you can be generating a lot of savings for CMS, but you're never going to get near the total cutoff in terms of the revenue that's flowing through the system. So, one of the things that we've been contemplating, sort of generally speaking, is maybe that should not be such a strict threshold. Is there a way to do this on a continuous basis? And I'm curious to get, our 2 key specialists in some sense here are John and PJ. So I'm curious to get your quick takes. Would that kind of a model be more activating for specialists and hospitalists? And do you think that would actually keep people in APMs more than saying, hey, I should just flip out of MIPS because the MIPS dollars are getting bigger over time? PJ, do you want to start with this one?
Yeah, I think it's certainly in our experience, with the value opportunity through participating in, specifically the condition-based bundle approach and the opportunity for specialists to, engage in this kind of more comprehensive approach to care. I think there's definitely enough levers to pull, and I think having that. I suppose agility or redefinition of those thresholds can definitely drive more engagement for sure. I think it's probably imperative that we do so, so that they can be part of the solution, so to speak, and having those that value opportunity there, I think will be a huge thing, especially as we start thinking about how to kind of level some of the playing field here between primary care, specialty care, and engagement. So
great. John, your quick thoughts?
Well, kind of, we thought a lot about the MIPS, kind of opportunity, but really, it just flies in the face of the basic economics of professional reimbursement for kind of hospital-based care. The average hospitalist generates 2.2 RVUs for seeing a Medicare patient during like a 5-day stay for congestive heart failure at $32 in RVU. That's about $75. And if under the MIPS program, you get a 5% uplift or even a 9% uplift, that's about like $7. And, it's just really hard to justify an investment of uncompensated time with those types of economics. So we've always advocated models that, involve the physicians sharing with the hospital in the overall shared savings, because that's really the only thing that would ever incentivize a physician to, invest a lot more time relative to kind of the other basic things like just seeing as many patients as possible.
Got it. So Josh, you've done a lot of work on MIPS. Any thoughts on structuring the AAPM bonus in a way that's more inclusive or engaging of specialists?
I just, in the interest of time, I'd say I agree very much with what John was saying, and this idea of being thoughtful about gain sharing and sharing in the savings is a key area to focus on.
Great. Okay. So so we'll have time for one quick comment from each of you on outpatient bundles. So one of the key interesting things about TEAM is not only is it mandatory for hospitals, but it actually includes outpatient bundles in with inpatient bundles. And that's been new. So Daver, my understanding is there's been a lot less empirical data on outpatient bundles. Quick word on why that is.
It used to be there was less sample size, but now it's going up. So I think we'll have more evidence soon.
Okay. Okay, great. So more coming soon. Hopefully, if nothing else with TEAM, we'll get a lot more. Josh, your thoughts on, is this outpatient bundle thing in TEAM? Is it just like a nice feather in the cap of a good model, or is this something that's truly, can this be transformative? Can this really drive some savings?
Yeah, I look at it as an important shift in the right direction. Again, I think more broadly thinking about, outpatient bundles, where kind of in where it's assigned versus like where it actually happens, and thinking more broadly, though not applicable to every type of thing that we want, outpatient, ambulatory, inpatient. I think there's a lot of potential savings and really more importantly, changes in care delivery that you can imagine happening there, particularly when you layer it on top of is it physician groups versus hospitals kind of leading these. So I think it's an important feature, but I think it speaks to that bigger point of where we're going to be able to trigger episodes. And there's a broader question about that in ambulatory versus inpatient or outpatient in the inpatient designation.
Great. Okay. John, thumbs up, thumbs down. Outpatient bundles. Thumbs down. Okay.
Thumbs
Not enough
down. I sort of get it conceptually, but whether it's diabetes or oncology or like outpatient surgery, it gets murky really fast with regards to trying to carve out what is distinctly sort of the specialist care versus what's encompassed in longitudinal care overseen by the primary care groups under an ACO arrangement. So I get inconceptually, but I think that if you think hospital-based episodes is complicated, ambulatory is a million times worse.
Okay, great. All right. So in the spirit of time here, I'm actually going to cut us off. Let's go to wrap up. So this was an amazing conversation. Thank you so much to Sarah for giving opening remarks, to the four of you for participating today. I think very stimulating discussion. We actually covered a lot of ground in the hour and a half that we had together. I think it highlights a lot of opportunity, but also perhaps a lot of work to do. Hopefully this was helpful to the CMS folks as well, who are listening on some of the key areas that they are open to feedback over time. So in addition to thanking all of you, I also wanted to thank the attendees. The audience has been really interactive. Thank you for that. Thank you for participating and joining. I also wanted to thank Nikki and Joe from the IT team who really made this whole webinar possible, to Dave, Deborah, and Tori and the whole Parity Center team who organized this. It was a ton of work. Big thumbs up and kudos to them. They deserve a nap this afternoon. Thank you very much to CMS, Daver, Sarah, and Liz Fowler and others for their engagement in organizing and getting this timed at the right time overall. And last thing is, remind everybody that please share this on social media. We will be actually taking this recording and putting it on the Parity Center website. So please, if you need to refer back to it, please don't hesitate to. And if anybody else missed it, please feel free to point them there. So thank you much again, everybody. We'll wrap up here.